Hi, Anita. Hello. Hi, Anita ji. I can't hear. I'm trying to change the name, but it's not coming. No?
Geeta ji, can you hear me? Geeta ji? Geeta ji.
Hi, Anita ji. Now it is audible.
Audible? Okay.
It is audible now. Yes.
I was just thinking. Now you can hear me?
Yes. It's better, much better. Okay. I'll be back later. Just
Sure,
drinking water.
No problem. Namaste, Mukundji.
Anita ji, namaste. How are you doing?
I'm doing great. Thank you. How are you?
I'm doing well. So I guess some of the students, scholars from Australia, New Zealand group have not met you, and you're not yet on that.
No, I have not met anybody
We
before.
should get Usha ji to add you to it.
Okay.
One of the scholars already asked me for your contact information, and I put that information in the group chat.
Okay, sure. Sounds good.
How are you doing?
I'm doing good, yeah. So things are just routinely busy. So yeah.
That's a good thing to be, you know.
Yeah.
It's much better than the other way around.
True. I just got a message from Pradnya ji from Australia, I think ANZ group.
Yes, I think she's the one who asked me for your contact info.
Oh, okay. Okay. Yeah, she just messaged saying that her group members are unable to attend and she will not be able to present today. I said,
Okay.
I'm not very sure about the new format, but I think that should be fine. They had some family emergency.
Okay, that's fine. You can just make a note of it
Sure.
and let Usha ji know.
Okay.
So this new format, essentially, each of the scholars has have formed subgroups.
Mhm.
So I think global plus Australia, New Zealand, there's probably 6 or 7 subgroups.
Oh, okay.
And then each subgroup elects a leader who presents at the session.
At the session. Okay.
After having reviewed all the material,
Mhm.
they'll present their key takeaways.
Okay.
And some things that commentary, they'll do that in about 5 minutes each.
Okay.
And then once all that is done, we will go into regular Q&A discussion.
Good. Okay. Sounds
And
good.
you will start the session, opening
With the
prayer or
prayers.
closing prayer.
Mhm.
And then I've asked Niluji to join. I think she'll be able to. So that'll be good. So she can also participate in the Q&A sessions.
Q&A session. Okay. Sure. Instead of Sunday afternoons, we are utilizing our Friday evenings.
That's right. That's right. Yeah.
Namaste Mahaji. Namaste Prachiji.
Yeah, I see a few people are already on.
Yes, I'm here. I'm sorry, I'm eating. I'm just finishing.
No worries.
Namaste,
Can I get
Mukunji
some of that?
Sorry?
Someone said they were eating, so I said, can I get some of that? You know.
Yeah.
Absolutely, absolutely. I'll send some over.
Yeah, just fax or WhatsApp, any technology will do.
Yes.
Yeah, WhatsApp is quicker.
Maybe pretty soon in our life, even that comes in too. So.
I know, right?
Namaste Mukunji and Anita ji.
Namaste Mahaji. How are you doing?
Doing well, thank you. How about yourself?
Good, thank you. Back
Sorry,
from
I'm a
India?
no, I'm not. I am from
Okay.
India, but I'm right now currently here. I'm sorry, I'm a little bit overdressed for this, but I'm just jumping
No.
from one thing to another thing. And
I
no, I
see.
had a presentation to do to the little kids about India
India.
culture and
Oh,
language.
nice, nice. I see the India
Well,
flag in the background.
Mahaji, you're just going to make up for my sartorial elegance. So
No, I know I'm overdressed. I'm sorry, but I didn't want to like come late. I might as well switch from one Zoom session to another.
Namaste Niluji.
I see Niluji's on. Welcome, welcome.
Namaste,
She's on
Neeluji.
mute.
I think the scholars will be very excited to be
Namaste.
interacting with you, Niluji.
Oh, hi there. What's that?
Scholars will be very excited to interact with you today. So
Yes.
get their questions answered and so on. So
Of
glad you
course,
could
well,
make it.
you are a content expert as well, Mukund.
Namaste, Mukunji. Namaste, Niluji.
Hello,
Namaste.
how are you?
I'm fine. Thank you very much. How are you?
Good, thank you.
Thank you. Really liked your video. It was really impressive,
Oh, thank
taking
you.
us to the new world.
Yeah, thank you.
I'm unable to share for some reason. So,
My video.
Mukunji, are you the host?
No, but I can make you the co-host. Just give me a
Okay.
second here. I think I have to claim host here. Give me a minute. I'll
Sure.
take care of it for you. Okay, so Anita ji, I've just made you a co-host.
Okay, sure.
So
Yeah, it's allowing me
it's
to.
1 minute past the hour. Let's wait another maybe 5 minutes max, and then we'll just get started.
Sure, sounds good.
And scholars will join in as time goes on.
So how is Friday going so far for everyone?
It's good. Thank you. It's good.
In a sense, my Friday will start after the session is over.
Yeah.
Mine will
Okay.
end after the session is over, so I'm looking forward to that.
The weekends, right? So weekend begins after the
Weekend is
class.
busy, yeah.
We are all in different time zones, right? So
Yes.
No, I think same time zones.
I meant mentally. So we have 13. Yeah, let's give it another 2-3 minutes and then.
Sure. Yeah.
How are you doing, Mukund?
I'm doing well. Been very, very hectic.
I can tell with all the responsibilities that you're piling on.
Yeah. And congratulations, Mukundji, on that article.
Yes.
It was very impressive
Thank
and
you. Thank
a lot
you.
of insights into life and overall perspective of life, I guess.
Yeah. It's a
I,
beautiful article.
Lot to learn from that article. So
Well, I just this afternoon finished a 1-hour long interview with a doctor who's known as the palliative care father of palliative care in India,
oh wow.
Oh, Dr. Rajagopalan?
Dr. Rajagopal. And I'm going to be writing a feature article about him that you'll see later this month. So I spent an excellent hour talking to him and lots of
Insights.
facts that he's told me that I'm trying hard to capture, so.
That's awesome. Are you going to be there on Sunday, Mukund?
No, I have a conflict with the Sunday event in Milpitas, but he is going to be doing a book reading in Stanford on Tuesday.
Oh, nice.
So I'll go for that one.
I see. Got it.
All right, so
It's done.
Anita ji, let's get the session going
Sure. Okay.
and we can move from there. So.
I would like everybody to sit straight and let me share my screen for the opening prayer. Okay. Put your hands together over your heart. Close your eyes. Take 3 deep breaths and we'll chant Om for 3 times. Om. Om Sahana Bhavatu Sahanau Punattu Sahaviryam Karavavahai Tejasvinavaditamastu ma vidvishavahai. Om
Shanti,
Shanti
Shanti, Shanti.
Shanti. Good evening, everyone, and welcome to session 22 with Dr. Mukundji and Neeluji. And today we would be talking about HEAL 300 and also Plan 300 topics that we will be talking about. And I hope everybody is ready for the discussion. And I know for some of you it's good morning, and some of you probably is good evening and good night for some other parts of the world. So welcome to the Friday session. So over to you, Mukundji. Oh, sorry. You would like to say anything, Mukundji?
Yeah, you can stop screen sharing.
Yeah, sure.
You don't need that. So let me add my welcomes to Anitaji's comments. I'm hoping we can have a delightful discussion this evening. So without further ado, all of you know the format. Each of the groups has chosen a group leader to come today to make a presentation of the key takeaways that that group had from after having viewed the lectures, and point out any particular things that they wanted to focus on or just have a discussion about. So we will have each of the groups in turn go through and do that presentation, hopefully in 5 minutes each. Let's try and keep for 5 minutes. Anything that's left over from what you wanted to say, we can fold into the discussion session that we will have after that everyone's had a chance to do their presentations. And I'm also delighted that Dr. Neelu Mehra and Neeluji especially made the time to come and attend the session today to be able to participate in the discussion and answer any questions that you folks have. So welcome, Neeluji, to the session. Very glad you could make it. So I don't know who are the group leaders and who are all the what the sequence is. So I will just ask you folks to self-identify as leader of the group. If you have groups number 1 to 6, let's start with 1 and go from there, unless someone wants to change the sequence for some reason. Do your presentation and then we'll go on to the next group. Is that okay with everybody?
Okay. Okay.
Excellent, thank you. So can someone, if there is a group number, are there group numbers first?
Yeah, I'm just seeing in the chat from group 9, Ushaji will be representing the group. Is there anybody who wants to go first before that, or?
That should be fine. I will go later.
Okay. Okay.
So can you, who's the group leader? Can you identify yourself and then come on the screen and talk, please?
Yeah, I think Ushaji is on the video. Yeah.
So I'm from the ANZ Group 9. Actually, currently I'm sitting in Singapore, but we had our group discussion. 3 of us met, and all 3 of us felt that the presentations were really very clear. Dr. Neeluji, I really enjoyed. All of us enjoyed your presentation. What we took back from the presentation was that palliative care and hospice care are similar and yet different. Both involved multidisciplinary care. Both addressed quality of life, and both can be provided at home, in hospital, or in a nursing home. The big take back about palliative care was that it is initiated when the progressive illness is diagnosed. And it is more on a symptom management to prolong quality of life. Well, hospice care is provided towards the end of life, and it focuses more on symptom relief. And this was really a big eye-opener for all of us, because we always thought palliative care and hospice care were quite interchangeable, but we can see the big difference that it is now. And then my question for palliative care is whether can it be initiated only by GPs, or can any healthcare professional or family member or carer, can anyone come up and ask for palliative care? That's care and hospice care. Then on the topic, Mukunji, your explanation, really, it was really a big discussion point for all of us. We talked about our family members passing away and what was done different, what could have been done, whether did we follow what they wanted done, and because all our parents didn't tell what they wanted. Or when our fathers or mothers passed away, the other partner did things the way they wanted, not taking into consideration what the person who passed away did. So it really, having the conversation with the family, that was really something that we all took back, but all of us thought that it is a problem that we will face. How are we going to start it with a family? Because as you bring this up, nobody wants to talk about it. They don't talk about it now, and it's pushed off. So we took back from Mukunji, your talk was that we have to decide and let our family know what medical intervention we want at the end of life. And we have to decide who's the person who can do it. And we have to, but again, I think all of us said that it's going to be a very difficult topic to bring up to the family. And I think the Asian family, wherever you live, whether you are from the Indian subcontinent or whether you are from the Asian continents, whatever it is, we don't want to talk about it at all. You don't want to, the young people and the old people, both don't want to talk about it. The other thing we all felt, we have one person from Perth, two people from Perth, one person from South Australia, one person from Sydney in our group. And we felt that the Australian part of it was not mentioned at all. We kind of felt that it would have been great if there could be someone, a health practitioner who dealt with palliative care in Australia who was involved in this course. It would have done a lot. I think in Australia, the population is mainly in the big cities, and the big cities are all in the coastal areas. So like life in Perth and life in Sydney and life in Adelaide in South Australia, it's very different. The people are different, and so that has to be addressed in this course. That's what we all felt. In Australia, I find that every time there's an election, they bring up all the healthcare issues. So this year we had elections. So in 2022, there was a study done, and they're finding that palliative care, although I think it was started in the 90s, but there's not much information available out there. And they did a study in 2022. We just had our election. So they did a study and they found that 3 in 10 Australians, only 3 in 10 Australians understood that a GP can palliative care. In our group, none of us knew that. So that was really, really interesting for us. And I mean, on the whole, it was a fantastic presentation. And really, I feel like in fact, we all said that probably our own dollar project should be on this in Australia, which is something that we all talked about. Yes, thank you very much.
Ushaji, thank you for that excellent summary.
Thank you.
A few quick comments. I think you extracted the essence of both lectures very well. You captured those features. Of course, there's a lot more detail, but you did capture those essences. Some of the comments you made, we will go into detail when everybody is finished, and then we can have an hour-long discussion about that. But I did want to respond to the comment that you made about not covering Australia. There are 2 reasons for that. We changed over from the old format to the new format midstream. And so the lectures that you saw from Niluji and me were actually done for the last year's cohort. Yes. And we had those recordings for you. We had no idea at that time that there would be scholars from Australia and New Zealand on the call. That's point one. Point two is, even if we did, the rules for advanced directives and so on are completely different from country to country. And as long as you capture the essence of why we need advanced directives, why you need to have the conversations, how complex it is, what are the things you need to talk about, you have gotten 95% of the lecture.
Right.
Filling out the form and figuring out what the local rules are all, you can go to a legal or a county or a provincial office and get those things sorted out. So we wanted to focus more on that, the human content, the important content, having the conversation, the understanding of the role of different people, and so on and so forth. But we will make a note of your point and see if we can find any. The thing is, it's better not to say anything than say the wrong thing as far as these legal things are concerned. So I would be kind of hesitant to. I've know enough about advanced directives in the US that I can talk confidently about it, and Niluji can correct me when I make a mistake, right? So I have a partner from that point of view.
Yeah.
Anyway, those are the comments I wanted to make. So thank you. And if to both you and to everyone else on the call, as you have questions, either note them down or put them in the chat. And once all the group presentations are over, we'll go over those questions and have discussions. Thank you. Thank you.
Thank you.
Anita ji, who goes next? I see
Geeta
from the
ji can
chat.
go. Geeta ji can go next. She's from group 1.
Okay, Geeta ji.
Geeta ji, you're on mute.
Sorry.
No worries.
Namaste, everyone. Mukundji's and Niluji's videos are really completely new to us. They are opening the door for a complete new world. When we watched, when we took the class of, Mahadevanji about hospice care, what the hospice patients want. So I think this is the answer, how HCI team and faculties and elite team, they were taking us to step by step to the, they are readying us for physically, emotionally, and spiritually preparing and leaving us to the new world. That's how I felt about it. So this is the when we are not ready to accept that mortality, then become the problem. When the mortality is no longer an abstract concept, then healing becomes a creative act of reimaging of life amidst the reality of sufferings. So I think there starts the palliative care work. So at the end of what we want at the end of the life, or what we want in the end, we want just shortly to say truth, touch, and time, physical comforts, mental emotions, and spiritual needs and physical needs. These are all the things we want, but it is really, we are hesitating to accept all those things. That's how our HCI team, HCI faculties are preparing all the scholars. Thank you very, very much, Niluji, for to make us strong, to make us accept all these things in a well-prepared way. We have to, a man must elevate himself by his own mind, not about how we will die. That's what you mentioned, not about how we will die, how we will live our end of life. At the end of life, how we are going to live, that is more important. And live with our all family members and say goodbye to the world by touching the line. That's how, it is, everything is touching, and at the same time, it is making us nervous. All the question and answers, they are all, I remembered one quote from the Bhagavad Gita, Manaiva Manushyanam Karanabandha Mokshaya, means allow the mind to indulge in super consciousness to reach super liberation. that is possible with taking in a scientific way, because we are having so much of medical facilities, which we don't know at all. So what is the palliative care? What is the hospice care? Just we are a little bit heard about them in the last classes. Other than that, we did not hear about that. So when we have to take it, so that is all depend upon the person's needs and person's physical and mental needs. When he has to take palliative care, when he has to take for hospice, it is depend on the person's priorities, both financial, physical, and everything about his own. With regard, I think both are combining. One leads to another. That Mukundji's video is dependent on Niluji's video. So I feel both are dependent to understand that one. With regard to the advanced directive care planning and physical posts and DNR, there are some new words. So, but we have to study all of them to understand how we have. They're all you told. There are like a toolkit to take charge of them. So how we have to follow step by step, one by one, and there are like about our how we have to follow them at the end of the phases of our life. I think I have to really understand in detail to even to understand that one. I need more time. What about the palliative care and what about the hospice care? So my question is also: is it really available for the person who is having some mental ill health? So I read it in some other sources. Yes, it is available with if person is having a mental illness because of the chronic ill health. If that is caused by chronic ill health, yes, definitely they have the facilities. But if the chronic health itself is a mental ill health, so do we have that one? So I did not find answer for that one. So I need more information for that one from you guys. And I liked your Frank's example. It is really helpful and it is heart touching also, how he managed and how palliative care team and how hospice care team helped him. So even I got the question, I got doubt. So if we have to ask our Kaiser or our healthcare agent. So if we are any part of the world, if they are having the team there, so at that time, is it palliative care is helping us to sort out the issues, to take care of the patient? That is my one question. So at the end, I really want, HCI itself is acting, HCI, all the scholars and all the faculties, they are acting as a palliative care and hospice team for all of us and showing the way to solve the problems in all, how Bhagavad Gita shows where the Jnana Yoga, Karma Yoga, Bhakti Yoga and Raja Yoga, like that way, our HCI team, they are helping us to sort out the problems and reach to solve the problems, to reach sort out our issues. How this how in yogas we have panchakoshas, how to clean up them. In the same way, HCI team is acting as palliative and hospice care. And I really impressed by your Sukham team, Mukundji, the missionary statement and how it is helping the patients to acting as a core team and a holistic approach and integrated approach of the team. Yes, that's what I have read, and there are so many things to understand that one. But at this point, I remember all this this much thing. Thank you very much.
Thank you so much, Geeta ji, for your feedback and your thoughts. I'll respond with a couple of comments, and the rest of it we can hold over the discussion. I think you said very rightly that in order to understand how to fill an advanced care directive and how to have the conversations, we also need to understand what palliative care and hospice care are about. So the two concepts are linked, do have overlaps, and which is one of the reasons why we had those two lectures together in one session.
Yes, sorry. Actually, we had a discussion with our team, and in our team, there is a She's Lakshmiji is there. She explained everything again in detail. Niluji is after watching the videos, and we discussed with her. She also again it's one more session for us. Thank you.
Excellent, thank you. And the other comment I would want to make is that you rightly said that what we have done with these two presentations is to kind of open the door for you to introduce you to some of the concepts, introduce you to some of the challenges, to talk to you about all the things that need to be done. It is up to each of you going forward to take as much of that as you want, learn more, study more, and implement more and practice more. So that's what any sort of certification is. It gives you the, let us say, the first chapter in your education, and beyond that, you have to build and develop on your own. Those are the two comments I'd make.
Absolutely, Mukund. Thank you.
And the rest of your questions that you had, we can hold for the discussion session.
Thank you.
Thanks. Anita ji, let's move to the next one.
Sure. The next one is group 5, JMT.
Namaste, everyone.
Namaste.
Usha ji and Geeta ji covered most of the points that I wanted to raise, so I will not repeat those. Thank you very much for that. So I have to rearrange my thoughts. So pardon me if I sound a bit disjointed or not proceeding in a logical way. First of all, I wish to thank both Mukundji and Dr. Neelu for the work that they do. Mukundji, I think if you can provide us more information about the Sukhum. When I heard your talk, I was wondering if we could do something like that here in Canberra. So I would be really interested to know more. And Neeluji, your job must be so difficult among all the faculties. I suppose your area would have the most number of patients who die, and that must be devastating for a healer and a doctor to deal with. But today, if there's time, I'm interested in energy medicine, sound medicine. So if you can throw a bit of light about your energy medicine and the integrated medicine part, I would be very keen to know more or provide some links. What Ushaji said about the Australian context is what I was feeling as well. But this topic is not new to me. More than 10 years ago, I attended a lecture about having the difficult conversation, which is about this. And I was actually looking for a PowerPoint that I thought I could share with the group, especially the Australian group. I couldn't find, and I thought, okay, those days they must have given us a handout. So I'll have to go through all my notes, and I don't know if I'll find it. But just for general, our Australian people, there is an institution or association called Healthcare Consumers Association, and it's got branches in different states and territories of Australia. I attended the one in Canberra, and they do this quite regularly, having the difficult conversation. And also what you said, they use the term more health power of attorney. So that's what I was familiar with. And the other is there is a public trustee also in each state. And very recently I attended a talk because I'm on the policy committee of the Council of the Aging, which is also all over Australia, but we have a branch here in Australian Capital Territory, ACT. And the public trustee, somebody had come and spoken to us about their work, and they also do this kind of work. And they give the questionnaire, so you can go through and you can decide and then discuss with your family. Another difficult, if you want to go through difficult conversation, I would also suggest going through Donate Life Australia's website. That is only about being a donor. So when you decide to be a donor, what kind of conversation you wish to have with your family, so that they will, respect your wishes when you pass away. So there may be some pointers out of that Donate Life website as well. I think it was discover, discuss, and then decide. That's what it used to be when I worked there in policy area. So these are some of the thoughts that were coming to my mind about Australia. And just like Ushaji said, this is something one of us or many of us can take up as $1 project. And I already spoke to one of my quota policy committee person, much older than me. She has all this in place, and I'm going to meet her. I wanted to do it for myself in a good way. But again, if you have a hard copy, it may be difficult for you to carry it everywhere and for people to be aware that you have all these end of life decisions. So she said that she put it up electronically in the Australian system. But I have a lot of concerns about putting something on an electronic format in a system because there have been a lot of security breaches. One that I can quote is about the Red Cross here. They were supposed to keep all the blood donors list very confidentially. But something happened and all the details, names and blood groups and everything was made available. And, after that, when they say sorry, it really doesn't cut. So somebody in the organization is not trained or is a new employee. This is the excuse they give. And then there are security breaches. So we need to find out more about that. And within Australia, I suppose they might follow. But if I travel to India and I happen to die there, or I go to US or UK, or, we are all people who travel a lot. Despite COVID, people have started traveling now. So whether there is a global way where our end of life wishes can be fulfilled, I don't know about that. Need to explore that. And another thing, very, very embarrassing to admit in a big group, but I'll do it. Neeluji and Mukunji, I lost the lecture somewhere, so I'm still not sure what is the exact difference between palliative care and hospice. If you can cover that, there seems to be a very fine line between the two. And my final thought, you had mentioned, Dr. Neelu, that one day's charge is about $350 in the hospice, or something like that, which is phenomenal. So probably we have to work here with the Federal Department of Aging or something, because aged care as such in Australia is very expensive when people move into aged care or independent living. So we need to explore this to make it more affordable for everyone. So thank you again and namaste.
Thank you, Jayantiji, for that very succinct and clearly stated summary. A couple of thoughts and a couple of comments. I think it's a very laudable idea that you have picked up, and a couple of others mentioned also, about trying to find out what the system is, what the requirements are for advanced directives and so on in Australia. Whether you do it as an $1 project or whether you do it outside the $1 project definition, it would be wonderful if you did that research and sort of developed a clear, let us say 3 or 4 page description of what things are like in Australia. And by the way, I noticed that Milinji also had some comments in the chat that he had some information. Perhaps some of you can get together to do this. That'll be useful in different ways. You can share it with the entire scholar group in Australia and New Zealand, as well as your community. Plus, I would feel honored if you shared that back with me. So next time I'm asked about Australia, I can talk about it with a little more confidence than I'm able to now. So that's one thing I wanted to talk about. The second thing I wanted to say was, as far as the difference between palliative care and hospice care are concerned, energy medicine and so on, we will give you that discussion, but let's wait till everyone's finished their presentations, and then we can bring, if we do not bring that up again in the group discussion, um, please remind us about it.
Okay, I'll just add, Mukunji, yes, if I prepare anything, or shall I say when I prepare something, I will share it with you and the other scholars.
Absolutely.
And I had one more thing which I forgot to add, is many of us in this cohort, we are not counselors, we are not having all those recognized qualifications. We are doing this course, the Hindu pastoral care. So I don't know if at all, wherever we are offering our volunteer services, we would be allowed to speak about end of life care and all these documentation being in place with the patients. There may be some rules and regulations. As a person, this may be very valuable, but as a volunteer or after doing this course, I'm not sure how applicable it's going to be. I forgot to add that thought before. Thank you.
And I think, Jayanti ji, you raise a central point about what we can and cannot do once we are certified as counselors of Hindu tradition, as CHTs. What we've given you is a knowledge base and some skills in order to be better informed and be better able to do service in your community whatever way you want. We have to be very careful in terms of not crossing the line of doing things that require, at least in the US, professional licenses. We cannot prescribe, we cannot recommend, we cannot advise. We should not, in whatever sphere in, attempt to do those things. All we can do is to be there for that person who is in distress or in need, and use the knowledge and information that we have gained to be able to direct them to the right authority who is able to provide that next level of consultation that one would want. So I think regardless of whether we're in Australia or South Africa or in the US or in India, wherever, we need to remember what our do's are and what our don'ts are as far as volunteers are concerned, regardless of whether we have the CHT certification or something else, right? Neelu ji is a licensed medical professional, but she is still unable to do things that she is not authorized to do in spite of her expertise, right? So she has her own boundaries and own limitations that she cannot cross. There'll be some medical situations where she will say, I cannot do this diagnosis, I cannot make this consultation, I refer you to an expert to do that. So all of us have to learn to live within those boundaries. I'll make one more comment and then we'll go on to the next presentation. And I see a hand is up. We can save those questions again for discussion. You mentioned a little while ago, Jayanti ji, something that's important, that you were concerned about putting your advanced health directive on electronically. For one thing, our modern systems are going electronic. Whether you know it or not, a lot of your stuff is already out there electronically. Here in the US, as far as advanced directives are concerned, the system basically is every medical facility, every hospital, every nursing home has an electronic medical record system called an EMR. Every patient has an electronic medical record in that hospital or nursing homes or facility system. And our advanced health directive is scanned into that system. So any professional dealing with you in that facility has access to our advanced directive. That works, as you mentioned, as long as you're within your local sphere and you're dealing with the local medical system. When you cross boundaries, even in the US, go to a different state, or when you go to a different country, that may or may not be possible, in which case it helps for you to have informed your relatives and your loved ones what your wishes are, So people who are contacted, when something happens to you, they're likely to reach out to your relatives. They should be able to say, represent your voice and say, these are their wishes. So it's critical for you not only to make your advance directive, but with all those in your close circle, you should inform them about your wishes and discuss it with them, right? In addition to your healthcare agent or healthcare power of attorney, whatever it is. So those are the comments I wanted to make. So Anita ji, we can go on to the next.
Sure, yeah. Next group is Prachi ji's group, group number 8. I think Australia too.
Yeah. Thank you so much, Anita ji. Mukunji, Niluji, and HCI, thank you so much for this eye-opening session. It really was eye-opening in a sense that when I have been, like, we have all been hearing about these lectures for quite some time. And yesterday was the climax of the peak of the whole thing, I would say. To some extent, it did make me anxious and make me nervous as well, thinking about all those things. And for a little while, I thought I'm not going to even think about these lectures for at least a couple of days. So for someone who's like, in her 40s and don't have to deal with these things, it was very nervous for me. So I can imagine how it would be for people already on that path. And but I think it is time to think about it, take a step and think about it, and plan out a few things for us in future. Regarding palliative and hospice, the way I understood is palliative care is when the illness is diagnosed. So that doesn't mean that person's necessarily going to die. But it's mainly regarding the management and how it can be cured or at least kept at a bay. And hospice is where the person or the patient is nearly at the end of life, and it's mainly related to management of symptoms and not so much of the cure of the disease. I figured out that the family discussions regarding the management of illness absolutely do not take place in an Indian family. I don't know about the others. I don't know how things are here in Australia or in US, but they definitely do not take place in Indian families. So I don't know how we can, because if usually it's the older people who have been diagnosed with those diseases like diabetes or cancers, and we are, compared to them, we are younger generation, and usually, oh, you don't understand that, like, so don't talk about it. And so how do we start or even initiate those discussions with the family members is my question. So suppose someone is diagnosed with diabetes, or not even so much diagnosed now, but has been dealing with diabetes, for example, for last few years. How do we start the conversation is my question. Is because perhaps it's easy for you guys because you have been dealing with those kinds of things day in and day out. For us, it's just a couple of lectures we have heard, and now we want to bring that topic. So I don't think we are capable enough to deal with it, if there are any questions. So how do we engage with the doctors and things like that, and get that discussion going? I also noted that people who have been diagnosed with these illnesses back home, to be honestly a little underprivileged, because there was no such concept, even in Indian families in past, because the families were so closely knit. Some elders or some wise people from the family would butt in and help with those situations. But now with this maximum 3 or 4 people in a family, and we are obviously not in touch with the extended family that much. So definitely it's a big thing. It's very hard to speak with that person and plan for the way in future. So I think that was my question. How do we get those discussions going? Because if I feel the need, or if I feel the importance of those discussions, others might not feel it, and it will be one against the other. So I don't know how to deal with that situation. And the other question I had, it wasn't so much question. Ushaji is not here today, but she mentioned that her father had tremendous relief from, like, because of the palliative care that she engaged, and it was not just for the family members but for her fathers as well. So we would like Ushaji's input on, like, little, if she can like, put some light on how the things were, because even though you have told us what palliative care is or hospice care is, I don't know how the day-to-day life there of a patient is. So I really didn't understand the palliative or hospice to that extent, only the fine line difference. That's all I understood. So that's pretty much it. And as the colleagues mentioned, there's not much in Australia, or perhaps we are not aware of it. Milinji did point out a few things, and I would go and check those things out. But yes, at this point in time, it is I'm not aware of these things in Australia. So that's all from my side. Thank you so much, Mukunji, and thank you so much, Niluji. Thank you so much to all the colleagues for raising all the points as well. Thank you and enjoy your day.
So thank you for that, Prachiji. A couple of quick responses. First, as far as Ushaji is concerned, I will try and make a note and reach back to her and say that you wanted to talk to her about it.
Yes,
I'll ask
please.
Anita ji also to do the same. The main thing, my takeaway from your takeaway is that you have perfectly defined the social dynamics and complexity of our South Asian Indian family culture, right? It is not easier for me, it is not easier for Niluji than it is for you. I had a really tough time talking to my son and daughter-in-law and family, saying I need to discuss my advance directive and wishes with you. It is always, no, Dad, there's no rush to do this. There's always another time, we'll come back to it, and so on. So it takes an effort. You hit upon a very key point. How do we get these difficult conversations going? In the group chat, I sent out a whole bunch of links a day or two ago. One of them is about exactly that whole topic. There's an entire booklet about starting the conversations. And that book, if you look at the booklet, it gives you a number of different hints. And you look at those hints, and then you'll figure out what are your own techniques to start a conversation. And it might give you some ideas that are not listed there. But the key is to make people comfortable to talk about it, and understand the importance, why they're doing it. No one likes to talk about death. No one likes to talk about dying. But the understanding that when the event happens, it's too late to discuss it, that realization has to come through. Okay? The last point I want to make is, you also hit upon a key on what we as CHTs can do, what we as engaged scholars, engaged community members can do, whether we CHTs or not. We know the importance of this information. We can take it upon ourselves as a task to tell people what are the things, not what are the things they should do, but to preach the importance of medical care after 50. Teach the importance of understanding what palliative care and hospice care is. Teach the importance of having talk about the importance of filling in your advanced care directive, right? We understand the importance of these things. And if you notice, whenever I give my talks, in all the talks, I say one of the objectives is learn this. The second objective is to figure out how you can use this as a community volunteer, right? So you use your knowledge, use your information, whether it be palliative care, hospice care, advanced directives, dealing with grief, you know, all the other lectures that you've got in the knowledge-based domain. Figure out, how can I use my newly gained knowledge in this to influence my community members to also be thinking about it, also learning about it. And then reach out to local experts to come in and talk to you folks about it. You know, arrange for community meetings, arrange for different ways of getting things done. So.
Yeah, thank you so much, Mukundji. Our last few days have been extremely hectic, but I'll go through the documents. And if there's any questions, I'll get back to you. Thank you so much.
Yeah. I think, Anita ji, are there other groups that need to present? It's
I don't see anybody else raise their hand to present. I only had these 4 groups. Anybody that did not post on the chat and would like to go ahead with their group discussion?
Hello, can I?
Yes.
I maybe come in, yeah.
Yeah, we can hear you, Rajiv.
Okay, thank you very much. I am representing the group of 2 from South Africa, and I'm very privileged. I think I feel very privileged to be in this kind of an environment now, where very important topics are discussed. And I think that this topic, that is palliative care, and also advanced life directive, is one of the most important topics that were discussed during the course. And it's the most empowering one, if I can say that. And also it is very, very important for us, I think, at all age groups. In other words, the interaction of the person that has been, that is afflicted by a dreaded illness and is in a position where they are now very, very confused and scared. And then on the other hand, they're very close, family members that need to take care of them and also to make the very important decisions. And everybody thinks that they are doing the best for the other person. The person that is sick also thinks, you know what, I don't want to, how should I put it? I don't want to give the other person a lot of trouble and so forth. And then the children themselves may be thinking, how can I best serve the parent during that time? So it is a very, very confusing time. It is a very stressful time. And there's a lot of pain, apart from the pain that the person that is afflicted going through. In the South African context, for us, there is a stereotype kind of a relationship between a patient and the doctor, where it looks more often than not a top-down approach, where the doctor would say that they know it all in terms of what is the best treatment and so forth. So that is a barrier that needs to be broken, I think, on our side, where a patient and the family also takes a proactive role and a responsibility for the treatment of the patient, insofar as the non-technical things go. And also, there isn't much dialogue with the doctors where they come and explain to you exactly what the situation is. It is generally made soft, that is the dialogue, with a lot of maybe encouragement that things are going to be okay, things are going to be okay, where in fact, maybe they are not okay. So there are many false kind of, I wouldn't say, intentionally, but just to say, well, you know what, it's going to be fine. So those are the things that we are faced with, and I'm sure that we as people that have done the course from our country, the 2 of us, need to navigate. How do we go and break this barrier of communication? And I think that that is an important part. In terms of the course itself, we found that it was amazingly clear and open, and both the presenters, Mukundji, and the good doctor, presented it in a very open way and in a very sensitive way also, because it is a very sensitive subject. And we thank you for that. We will be, I think, approaching you after the course on saying how we can set up this dialogue and put a structure that is probably unique and customized to our own experiences here, to our own interaction with our own health people and so forth. I think I'll stop there for now, except to say also that, from a family point of view, we have gone through a very traumatic experience also of a family member, a very, very close family member that went through this whole trauma of, being diagnosed, and also how the whole family handled the whole process. And if I knew then what I knew now, I think I would have advised my brother on how to at least handle this, because his wife was on a ventilator for 65 days. And, that was very, very painful indeed. She passed on in 2018, but I think that it, for her own, state of mind and comfort, and also the family, what we're talking about would have been very important to relieve quite a lot of the pain. I will stop there now. Thank you so much.
Pichiji, thank you so much for those insightful comments. A few responses to you. The phrase you just used, if I knew then what I know now, right, is something, if each of us looks back in our own lives, the number of times that phrase would have been applicable is you can just count them. I can count them, right? We can all do that. So that is a key takeaway for this entire course that we are offering you, CHT. We are offering you some learnings from which you can use as a springboard to help yourself, help your family, and hopefully help and serve the community, right? The whole message about advanced care directive is the word advance, planning ahead of time, which covers the if I knew then part of it, right? That is key. And I think I want each of you to retain that phrase in your minds and apply that sense of regret to governing how we live our lives and how we learn in the future. I think that is probably a critical takeaway that you can get from today's session. A couple of other points. It's not just in South Africa that the doctor is considered all-knowing and unquestionable. I know several doctors in India who would feel insulted if the patient asked them a question, because they would take it not from the perspective of the patient wants to understand, but the patient is questioning my authority. What right does he or she have to do this? I see that a lot. The doctor is a super figure who shall not be questioned, right? And many doctors, not all, many doctors are very good about communication, interaction, and so on, but there still are a few of those out there. Hopefully that number reduces in the future. The problem is when our diaspora from India, from South Asia come to the US, go to Australia and so on, they bear that cultural baggage. They bring that cultural baggage along with them. And so when we walk into our doctors' rooms in the US, for example, many of us are unwilling to question the doctor because we feel that the doctor may be insulted. And as you saw in our advanced care planning lecture, unless you understand what the prognosis, unless you understand what the options are, and these keep changing continuously, it's a dynamic thing. So it's a constant question of asking questions, getting feedback, and making decisions based on alternatives. So we have to learn that it is okay for ourselves to assert for ourselves, assert for our family members, ask those questions, and not worry about how the doctor is going to feel. If that person is a good doctor, they will understand why you're asking them. So that's the message I'd give you. So thank you for your comments. So Anita ji, I think we're open for a regular general Q&A, and Neelu ji, I will start with a question directed
Yeah,
to you.
actually, Pradnya ji wanted to go over her group. Do we have?
Sorry,
any...
did we miss somebody? Yeah, please.
Yeah. So
yeah,
she just joined, so she wanted to go over her
Pradnya ji,
group.
sorry, I didn't realize you were on.
nah, it just some time before I have written that. Namaste Mukundji and Anita ji. This has been very difficult topic, I would say, very difficult to digest, and HCI has given this. I think they're giving us courage to think about these difficult topics. We are just, I guess, getting mentally prepared to know about hospice care and palliative care. And these topics are very discomfortable to discuss, but we can, this is now up to us on how we can discuss about these topics with our family, close family, friends, and in the community later on. And as Mukundji, you have very nicely mentioned about how we can use this to go about it. I think that is very important thing, because when I listened to both the lectures, I had these thoughts, whether have we on our personal level thought about these things? If at all we have to think about our family members about these things, how can we go about it? There are few things which we can maybe talk to our GP to know about these things, how we can go about when we will be in our 50s and so on. So I guess these lectures, both the lectures, are actually preparing us mentally on how we can do about it. So I would like to thank you, Mukundji, Neeluji, and HCI specifically on this. So just giving us that moment to sit and think about it and do your role, I would say. So that is what I had. Yeah.
Thank you. So quick feedback for you, Pradnya ji. As almost everybody on this call has mentioned so far, these are very difficult topics for us. This is not easy. These are real life situations that we have to handle when people are in distress, in pain, maybe facing mortality, not easy to do. But nevertheless, it's important for us to understand, know, and be prepared beforehand. And we'll be much better able then to, we hopefully pray that no crisis comes our way. But if it does, when it does, we are better prepared to deal with them than we are otherwise. So that's one of the general takeaways that I would offer to all of you. Thank you. So Neeluji, we go into general discussion now, and the first question is from Nirupama ji, and it's in the chat. I'll just read it out to you. She said, I've had a good look at the Australian government health site, and the same concept of palliative care as Neeluji explained. Yet most of the material there is about end-of-life care, which is more suited to the hospice care scenario. In my view, it will discourage patients seeking palliative care and make them more fearful about the disease. Would you like to comment on that?
So, well, thank you for such a good discussion from all of you. And I have a few thoughts that I can share later on. But pertaining to this question, that's where we started this journey, even in US. And we're still struggling with it because it's so interchangeable, the concept and I think the step that HCI is taking to promote awareness around it is the first step to go to where we want to go to, because it's every drop contributes to an ocean, right? So palliative care is a very interchangeable.
Sorry, we lost the voice.
Yeah, I think her.
When we get palliative care.
So
Sorry.
Neeluji, sorry to interrupt. You froze for a few seconds. Can you just rewind a little bit and say what you're saying?
Oh, sure. Yeah. So I don't know where I lost you guys, but what I'm trying to say is that palliative care and hospice are the same umbrella, because you do get palliative care when you get diagnosed with a serious illness. Nobody would offer you palliative care if you were fine and healthy. So the distinction is that in palliative care, you can live well with those limited illnesses. You can actually live longer, because there's a lot of studies that have been done that you live at least 3 to 6 months or even more longer with palliative care versus without. So I think that is the key message that we will have to keep promoting until people start to understand the difference. Because with hospice, you have 6 months or less to live. Even on hospice, people live for a couple of years sometimes. So understanding the point that nobody has a crystal ball, nobody knows what is to come. How can we live the best possible way we can? Today, it may be palliative care. Tomorrow, it may be hospice. And tomorrow, it may be in and out of hospice. You can also graduate from hospice. So nobody knows when your end time will be. But what's important to know is what these services offer and how can they make your life better in the moment, when you cannot do anything about that illness, when you cannot do anything about the cancer that you have, and the end is inevitable. How can I live well today? So I'm not worrying about tomorrow is all we can do. And this is true in wherever you read, whether you go to Bhagavad Gita, Purana, Bible, wherever you go, the message is that there, between a stimulus and a response, there should be a pause. And either you can choose to react or respond, but that pause is important for us to think and say, if I'm talking about these things, or if I'm facing these things, is it what I really need to spend my time reacting to it? Or can I accept it and be in the moment and live the best I can? And that's what these two modalities allow you to do. Because death will come whether you have hospice or not. We all came with an expiration and we will die one day. That is, we don't have a choice on that. The choice that we have is how we choose to go. Are we going to go screaming and crying out this universe? Or are we going to go in peace and dignity and with grace? Does that make sense? Yeah.
Yes, Neeluji, the phrase that you used, between the stimulus and the response, there must be a pause.
Yeah.
I think that has deep meaning, and it probably applies in multiple situations, not just in a critical. It could apply to a disagreement between a husband and a wife, for example, right?
True. Yes, absolutely.
So
I mean, that is day to day. Even if when you're stressed, how do you even get illness? You get illness because you're in a constant state of stress, and you have this cortisol in your body that's always existing, and that eats away at you. So choice is yours. You have the choice. You have the control of how you want to be. And nobody else can trigger you to do something that you don't want to do. Oftentimes we'll say, well, he's being annoying or she's being annoying, and I am getting triggered because she's doing X, Y, and Z, but I'm the one who's giving the response, right? So I think that is where it can be applied to any life situation, I guess, not just in palliative and hospice world. So very true, Mukunji.
And one more detail. When we talk about palliative care, we talk about it applying to serious illness, chronic illness. There's a question also from Nirupma ji. Does it apply to common diseases such as diabetes? Can someone get palliative care for diabetes in your experience? Can you talk about
Absolutely. Yes. So diabetics do progress. Let's say if we're not taking care of our diabetes. So there are several stages of illnesses. And because in ideal world, as they get diagnosed, if you got palliative care for them, they'll probably not even get to the stage where they get so far gone. But since, just like cardiologists and gastroenterologists, there are not too many of us, so we are limiting our exposure to the people when they get really in a progressive stage, right? And we are promoting primary palliative skills so that every physician knows them, is aware of them, and is able to use them. But in diabetes, you can have heart disease, you can have heart failures, you can have kidney diseases. So when you are dealing with that spectrum, palliative care totally makes sense. And it's important to be aware and get them engaged early on, because the specialization that they bring in is to managing your symptoms and managing your medications that may be causing more harm than good, and optimizing them.
The one comment I would make in addition to what Niluji just said, at least which is true in the US, is that right now palliative care is a subspecialty medical field. That is, the most common way is to be referred to a palliative care physician by another doctor, just as they would refer to a heart specialist or to a surgeon and so on. So the question that one needs to think about here, and unfortunately it's a question of money. If you're under, if your insurance will not pay for that consult, if they'll not approve payment, do you have the money to pay for it? Or can you ask your physician to make that consult, that referral in such a way that it will be covered? So there are ways of getting around that, but that's another issue that one has to consider.
Yeah, it's covered.
Can I say something, Niluji and Mukunji? Yeah, thank you very much for both of those very, very useful lectures and for your time to come and answer our questions. That's wonderful. Niluji, your palliative care description in terms of like living well, not dying well, so completely changed my perspective. If somebody would have referred to me before for palliative care for any disease, I would be really terrified. But thank you very much for changing my understanding. In my own family, I have had this issue that somebody is diagnosed with diabetes and then they progress to heart problems. I mean, they are well, they are working, but this concept I'm missing. I have been searching for this holistic care and asking GPs, asking all of their specialists, how can we coordinate this care? And nobody could guide me. But the way you have described, really, I would like to do something for Australia. I looked at the website, the palliative care website beautifully described what you said. But when we click on the tabs, it just takes us to end of life conversations, end of life care and all that. So with that, if somebody like me, a normal person looks for, and if I'm looking for palliative, I would be very discouraged, because I would think I'm not near the end. It is just taking me towards that direction. So thank you very much. I think I have spoken to Milinji. If we can do something like could write a paper or something, maybe JNTG can help for Australian, like all our group, that if something can be taken to policymaker and those websites could be revised, that would be, I think it would be a wonderful contribution from our side. Apart from that, I have just thought that in Australia, there is a system that GP can make a care plan. So if somebody is diagnosed, for example, with diabetes, they can refer you to a dietitian, to physiotherapy or something, whatever you need. Maybe that could be kind of part of like palliative care. Like there are only 10 sessions. They can include the mental health care plan there too. Probably that is kind of thing, but nobody has described it like that. And lots of people don't know. Physicians normally do not suggest. I spoke even to some of my friends here who are doctors, and my own supervisor, because I work in clinical research, and still they define palliative care as a near end of life. So maybe the physicians also need to be educated. I don't know how can that happen, but it would be really good. And in relation to Mukunji's Advanced Healthcare Directive, wonderful concept and wonderful like take home message. And when I reflect on my younger age, I remember my grandparents saying that when I go, do not take me to hospital. I just want to die here. But slowly, I think with medical advancement, we started thinking as if we are immortal and all the medical technology will save us. And we started being scared of death.
Yeah.
So, yeah, I think those reflections are really good. And both of your lectures made me feel to reflect on that. So that's wonderful. I would like to work with other colleagues here. If we can form a group and do something towards this direction, that will relieve the huge medical burden, like cost, taxpayers' money, everything. As Niluji said, that my daughter works in ICU. She's a ICU registrar, and she describes me like 95, 96-year-old patients come there, and they spend so many resources putting them on ventilator and doing everything possible because there are no guidelines. I really appreciate, and I never appreciated her view before your lectures. Thank you very much.
Thank you,
Nirupama
Nirupama
ji,
ji.
this
And
is
Thank
if
you.
I may
Jayanti. I would
encourage
love
you
to
and
work with
Jayanti
you.
ji and Milind ji to get together,
Yeah.
Yes.
form a tripartite committee and come back to us in a while with information
High
on
Yeah.
level
together.
Every little
tripartite.
thing. Yeah. Every little thing matters because that's how we will promote awareness. Like I said, we've been doing in US for 2 decades, and still there are physicians who think palliative care is end of life care. So you're right. The physicians need to be educated too. And we have promoted a lot of awareness from all major universities, from, major hospitals, but still there's more to be done. So I totally appreciate that comment.
But Niluji, what do you think? Why there is shortage of palliative care physicians? Is it not an attractive field, or why
No,
people
it's
don't
a
go?
very new field, and more and more people are actually going towards it. There's not very many of us because the organizations have maybe a fellowship training, maybe 4 fellows, and each institution is churning out 4 fellows versus 10, 12, or 14. So there's not enough quantity of us to promote that awareness, but it's surely and steadily it's getting a lot better than where we started. So there is hope in the horizon for sure.
Nirupama
I
ji,
think-
in the US, palliative care was recognized as a subspecialty medical field just around the time that the iPhone was invented.
Okay.
So it is that new.
Well, for it to become a major field of practice, it's only 3 years old. So it was not even a major field of practice up until now.
I think it's what 2003, 2005 timeframe that the medical commission, whatever it's called, recognized it as subspecialty.
Yes.
More and more hospitals are beginning to have palliative care.
Yeah.
But there are several hospitals in the US that do not have palliative care still.
Or they have a version of palliative care, which is hospice.
Yes, that's
so
right.
It's not a true version of palliative care.
No wonder in Australia it's not advanced. If it in US it is in primitive stage, yes, it would be. I think it is something like ICU. I think in Australia ICU was separated from emergency very recently, maybe 10 years ago or something like that.
Let's move on to let's give other people a chance to have some discussions too. Any other, I see a hand raised from Jayanti ji. We have a question.
I was wondering if not this time, maybe we have 2 more weeks. Other than all this end of life, as a Hindu, I am also worried or concerned about my cremation. In the ACT, I was actually on the board of the public cemeteries authority here. We don't have a public cemetery that does cremation. We have a private one. So we have been trying to nudge the government to have a public, which is a government one. And it's still a work in progress. I would like to know, because we are covering from the Hindu perspective, after death, what are all the rituals, how the body should be handled according to our scriptures, and how cremation should be done. If those kind of things are also covered, I would be very interested in knowing about that.
So Jayanti ji, if you go to the HCI website, We do have a lot of information on exactly that topic. HCI started a program called volunteer services at this time of the pandemic to help people through the difficult times where they're having deaths in the family and not knowing what to do, what rituals were needed, whom to contact, which funeral home did cremations, where the priests were that could do last rites. So there's a lot of information that is available on the HCI website. And as you know, Ananda Core, I've talked about it a few times, is now being prepared for launch, first in the Bay Area, but some of this information will be available for all locations. We will also have extensive information on death events, last rites, funeral home contacts, memorial services, and the whole works. But information like which funeral homes do cremations, which funeral homes offer services for Hindus and so on is very, very local. We are going to start with the Bay Area, build it, test it here, and then we will make this what we call Ananda Core system available elsewhere. So people like you in Australia and South Africa and other places can also start a similar program, but with knowledge of your local institutions and your local priests and so on. So expect HCI to be working very diligently to start that process this year and then move forward and develop it. But in the meantime, look at the HCI website. There is information in terms of the timeline and events and other details there on the website.
Okay.
If you don't find what you need, please reach out to any of the resident faculty and we can help guide you further.
Okay.
I hope that
Thank
helps.
you, Mukunji. I'll check up the website. But one thing I was informed in Australia, because Dr. Neelu is there, I want to ask, if you die in your own bed, in your home, in your sleep, or in whatever other way, I heard that in Australia, they still take the body for the post-mortem. Is that how it works? I mean, can't you just be dead and cremated? Why should you go through post-mortem? And that is where all the delay occurs, because we are in Canberra, very small. We don't have the requisite technicians and others. So maybe they fly them or they take the body there. So all that post-mortem and everything takes a long time. By the time they release the body, it takes at least few days, if not a week. So the cremation doesn't occur as per, you know, if I wanted to be cremated the same day, it's not going to happen. So is that how it is in the US as well, Dr. Neelu?
Yes, so unless you are on hospice, where the team is already aware and they have all the documentation. Otherwise, if you're not on hospice and you're at home, it is a coroner. You have to call the coroner and then they have to decide. And most of the times the postmortem needs to happen to make sure that there was no unnatural causes of death. And once that's determined is when the body is given back. Or if you died in the hospital, then you can say we don't want postmortem. So that is still here as well, unfortunately, unless you have hospice on board, then you can circumvent that.
So in this directive, can we put, I don't want postmortem to be conducted?
Yes.
Even if I die at home, if I'm fortunate enough to.
Yes. And we do have that as part of the advanced directive, that I do not want a postmortem for my body once I die of any cause. So then you're absolving them legally that they don't have to really dig in and it's a natural death, and that's what they will assume.
Because even with Donate Life, I wanted to donate organs. Then later I realized actually they even donate the whole body for medical research.
That's
so
right.
I thought, yeah, why not? I mean, my body is just going to be cremated, might as well donate it for medical research. So I tried to find out some things about it. And they said, no, when you die, if there is a demand for a body at that time, they will accept it. Otherwise, they may not take your body. And the second is, even when they take your body, they will do the research, but they will then dress it up and return the remains to your family for cremation, which then was not very
Appealing.
appealing. Yeah, it was not, it was concerning to me
Yeah.
that they will still return the body. So there are so many little
True.
things. Yes, that,
I mean,
you know.
even for organ donation, there's a lot of logistics that they have to go through. We have to keep people alive in the ICU, and they have to have very specific rules. They will take it or not. So the family go through a lot of trauma as a result of it. And it's a process. So it may go perfect or it may not go well at all. So even in the hospital setting. So these things, they sound easy, but they're very complicated logistically when it comes to it. So specifying in your advance directive, this is what I exactly want, this is how I want it, is a direction. But what will happen at the end of it, it depends on what policies do you have, what regulations are around you, and is how much is the need. You may have 20 institutions around you and your body may be accepted willingly, or you may have no institution around that may not take the body. So then they will give it back to your family to say, now, this is your responsibility to dispose the remains. So,
but one thing which is a bit morbid, I have sometimes this doubt, and I don't watch much TV or movies, but I have seen, do they treat the dead body with due respect when they cut the organs or take out? Even if I want, suppose I have so many diseases, suppose somebody has, they can't donate their heart or lungs or kidney or liver, but can still donate skin and bone and the eyes, maybe if they are good. So do they then treat the body with respect?
oh, definitely. I mean, in
Dead,
US,
but nevertheless.
yeah, I mean, in US they do, because we do see that happening a lot in the hospital. So that is something that they're very, very careful about, because it's a very personal experience for the families. So they try to be as gentle and as compassionate as possible. But that may not align with what your thought process is or what you would have wanted for yourself, because culturally we are so different, and the practices that we have are very different. So it is a very hard confluence to have.
Yeah, so
Jayanti, I work in transplantation research in Australia, and the conferences.
Wonderful.
Yeah, so the conferences I have attended, I'm not a medico, but I'm a researcher, basic science researcher. The conferences I attended and the way they present, and they present some videos as well, they do treat it with very much respect. But yes, our cultural beliefs may not be honored, but in terms of just humanity, yes, they do.
That's
and
right.
Yes, there are some occasions, I think you may be aware that in one of the university, there was a case that some bodies which were donated for education purpose to medical students, there were some issues, but the university took action and they against those staff. So these kind of things will happen, but in general, it's all good.
Yeah.
We should have
I just wanted to add
like
one comment here,
HCI.
then we'll go on to Seemaji's
sorry.
question.
Sorry, Mukunji. I'll stop. Yeah, it's okay.
So what Neeluji said about they will treat the body with respect, but that is sort of a human dignity, human respect definition. Different cultures, different religions have different procedures and traditions to be followed. Those procedures and traditions may or may not be followed because they're generally unaware of them.
That's right.
Like in the Jewish tradition, there's certain requirements for washing the body in a certain way. Our Hindus also have that, the different kinds of rituals, right? So that may or may not be followed depending on where you are and what the circumstances.
But I would add, though, in palliative care, we are taught how different cultures respect their bodies at the end of life. So that is some of the things that we are actually even tested on. So making us culturally aware and sensitive of everybody's traditions and culture, but that is just the beginning. There's a handful of providers who are aware of these. And I mean, my hospital now they have a movement going on for culturally sensitive care. Because, how can you honor other people when you don't know their culture? So all of that is coming up, but that'll take decades for it to even become mainstream, let alone be recognized.
Yeah,
Niluji,
that's what I was
would-
going to add, that, if they can, like HCI, HCA, they can go and speak to these people about, this is our Hindu tradition of dealing with a dead body, that would probably help.
Can I just
which is
have
what
one
we are
comment?
doing with our program with funeral homes. Let's go on to the next question. Seema ji has been patient.
I
Yeah,
think
we
there
have-
Just have one comment, Mukundji, just one comment, very quick, related to
Okay.
this. Being a transplantation researcher, I would just like to emphasize that with transplant organ retrieval team, they are very short of time. They have to do things very urgently. So probably they may not be in a position to honor all those rituals before they retrieve the organ. They have to act very fast.
That's right.
So this is something to think about. Yes.
Yeah.
Seema ji?
Yeah, actually, I just have a simple suggestion for the faculty that organ donation seems to be a very relevant aspect of palliative and hospice care. So maybe for future students, you can include a couple of slides on this subject. This topic still remains a very ambiguous for me, and I personally would like to learn more about it, so that's all.
Thank you, Seema ji. So the floor is open for more questions, discussions, comments. There are several people who have, I'm looking in the chat to see if there's anything here. Otherwise, please raise your hand and ask a question. Yes, Rita ji.
Rita ji, you're on mute if you're trying to speak something.
Yes, I'm sorry. Yes, your both session is very eye-opening, very sensitive, and very informative. It's everything together. We had our group discussion and we discussed so much with our grandparents and parents and everything, and how hard it is to talk about it. I think it's not like only Indian, American, and everyone, because I have quite a few friends, and they're also afraid. They say, oh, you know what, let's not talk about that. We'll talk later. So some things happen, they always talk like that. But my question is like for the organ donation. My sister-in-law recently passed away and she was in a hospital, okay? And this is, oh, it's going to take longer time. She was a donor in driver license, but this is, oh, it's going to take too long for you. Do you want to wait that long? Just finish it off your funerals and everything. So I don't know why they discourage. And I'm like telling him, I'm like, no, she said in the driver license that she want to donate the organs. But they says, oh, you don't want to go through too much trouble and too many days. It will take a longer period. Do you want to wait that long for cremation and everything? And then her husband says, no. Yeah, we don't want to wait. So what is the reason the hospital do like those discourage, like, you know what I mean? And second thing is like, another thing is palliative care. A friend of mine, he was very sick, and I heard in your video that about that gentleman that, he did not have money. So he got the money for the palliative care. He went in Hawaii and he got all these things. But when you are here, when you have money and you cannot afford, because it's very expensive and you don't know your illness, how long it will go. So in her case, like, they had like about a month or so she came, and then everybody realized like, okay, it's too much money for them, our friends. So we decided like, okay, go every day and we'll spend few hours with them. So at least we can save their money. So is there any way, like especially when you have a money, but you don't know your, sickness, it costs like $130 or something per day. And she was not even cooking or anything for her. She was only taking care of her. That's it.
Yeah.
So can you just explain a little bit more about it?
And that is a problem here, because if you don't have money, you have a lot of support, because you can
Yeah.
qualify for state insurance, which is called Medi-Cal, and they pay the entire, they'll pay for the caregivers, or you can be in a nursing home or a board and care. Well, board and care, they don't pay, but nursing home, they do. So that is possible. But if you're in between, where you have enough money to not make that cut, then it is out of pocket. No insurance pays for caregivers. The hospice benefit is covered. They'll come maybe twice a week and bathe and shower. They'll come, the nurse will come manage the symptoms, but they're not doing day-to-day care. That falls on the families, and that can be very stressful and very expensive. That's where some people, when they have long-term care insurance, that pays out if you have paid throughout your life, and then that's the time to encash it. But what I have noticed in our Asian community, and it is not just South Asians, Indians, it is also the Chinese community, which is very closed off, Vietnamese, the entire Asian Pacific Islanders are very close to end of life discussions. And there are different reasons for it. For Indians, they think there must be something that they can do, and they're not telling us what they can do. And sometimes we're not open enough to ask questions. Sometimes they say, well, it's a taboo that we're not going to talk about death, because if we do, it's going to happen. So those are the things. And I think at some point, some generation will have to peel off those ideas or ideations that we have lived with all our life, and start to become more aware and more open. And it may start with our generation. We tell our kids, this is what I want, and this is how I, like Mukund said. The kids are not ready to hear it because nobody wants to face it. But when the time comes, it doesn't tell you when it's coming. I have a 22-year-old right now who's dealing with cancer. It's a very aggressive cancer. I mean, who would have thought at 22 she would be dealing with a life-limiting illness? So these are the discussions that 18 and above should have their directive, should know what they want, what they don't want. My son, who is 22, his friend died in an accident. So the calamity, when it comes, it doesn't ask you, are you ready or not? And they say you can have a fire extinguisher in your home. That doesn't mean that you want your home to go on fire. You're just prepared and ready. So these are the tools to be prepared and ready, which empowers you and gives you control. Because I also see the other side of the spectrum, where the parents have not said anything. Nobody knows what to do. Now the guilt comes in. Now the hope comes in, and people are struggling and on respirator. They never make out of the hospital. They never do. What we see in the TV is only lives in the TV. Only 1% of the people get off that machine and even leave the hospital. And they leave the hospital with either mentally incapable of doing anything or physically not able to. So I think I should get to decide what I want for myself. I don't want to be a burden to my family. I don't want them to be worrying about me and making decisions on my behalf that may not align with my thought process. So taking control of yourself is where it begins. We shouldn't even worry about it. Who's going to say what? What are they saying? You can ask questions in a variety of ways. If things happen, what is important to you? Walking, talking is important, or being in the bed is okay with you? So these are the questions that you elicit to get to know this person well, so that you can make those thoughtful decisions, even if they're not willing to talk about it.
Thank you, Niluji. Excellent. Sangeetji, you had a question? Please come off mute and ask.
Sorry about that. I have a question. So I think we touched upon the long-term care insurance. Is it cost-effective? Someone was telling me after a certain age, it's not cost-effective after maybe 60 or 55. Anyone, and how do we deal with this on a proactive basis? Because unfortunately, not everyone has somebody to take care of them.
Sorry, Sangeetji, your voice is breaking
your
a lot.
Connection is very poor. We cannot hear you.
Oh.
But best I understood you is you were asking about the cost of long-term care insurance
Yes.
and whether it was effective or not. Is that correct?
Yes. What is
After
become too
60 is
expensive?
effective or not?
Well, I think after 68, there's a lot of cost that goes into it. And, you know, it's rolling a dice, honestly, because you could be dead in your sleep and you could be struggling at home for months and months. And then I see a lot of my patients at my end, if having a long-term care insurance has been a blessing. I mean, that is the reason I got bought for me and for my husband too, because I feel that at that point, when you are in that middle category where you couldn't afford to take care of your loved one in the way that you wanted, that's where it comes in handy. So it's rolling a dice, to be honest. If you can afford it, I think that's a good investment to have, because when the end comes, it doesn't come magically. It doesn't come abruptly either. It is a very prolonged process sometimes, and that can cause a lot of stress and a lot of unhealthiness in the family. I mean, I've seen the couples that one person died and a month after the second one dies just from the stress of taking care of their loved one. So it's a lot of stress situation. So depending on what your dynamic, your economics is, so saying that whether it's worth it or not is a very black and white statement. It really depends in the context of what you're facing, what your financial situation is, and if you can afford it, it's definitely worth it, because you may not use it, but that's how all insurances work. Life insurance is the same deal, right? We don't think twice about buying life insurance.
So two quick comments I would make, and we go on to the next question. First is with long-term care insurance, especially, the younger you are when you get it, the lower the premium is, and you can lock yourself into lower premium.
That's right.
As you grow older, especially beyond 65, at least in the US, the long-term care monthly premiums are sky high.
Yeah.
And second, exactly what Neelu ji said, insurance is a risk-reward analysis. I look at insurance as something that I buy, but I hope I never have to use. So
yeah,
that's the way
I agree.
Milinji?
Quick thing, Mukunji. So, I mean, we are Indian Americans. I have an aunt from UK. She went to India because she, you know, and she has she could afford home care there. You know, of course, she's 85 plus. She can barely speak. She has some condition. Is it, I don't know, this is a wide question, but is that an option to go to India and get, you know, long-term care there if you don't have insurance? Or is that not very practical? I mean,
I don't know much about insurance in India, to be honest with you, but I do know that in India, that if you have enough money, you can buy services.
Afford.
How good those services are is a different question, but that's possible.
Okay.
And the insurance bought from there is not going to work here. And I also saw a comment in the section that in Santa Clara County, you can get in-home supportive care, in-home services. That is only when you qualify for Medi-Cal, which is for low-income families. And the cutoff there is that you can only have 2,000. You can make 2,000 and below a month, and your bank account cannot be more than 80K or something like that. The savings. So if you have more savings, then you cannot have in-home, because Medi-Cal provides that in-home supportive services where they will send caregivers to you, and it's included in the cost.
I think we have time for 2 or 3 more quick questions before the session comes to an end. Keeping an eye on the clock. So Milinji, you're next. After that, Nishtaji, and then Mahaji, you have the last question.
Thank you, Mukunji and Niluji. Now, my question was in relation with raising this topic with the friends and family members. And like I had this experience because we were trying to talk about it with very close family and friends. And the people started crying. And it was like very difficult. Means I was not expecting that response out of it, but the people say, hey, you know what? We don't want to think about it. And it is like very, very much, we don't want to think at all. So my question was coming up is how to raise it when this type of things coming up when we are talking. And second thing was coming up is, okay, suppose if I put my advanced care plan as of now, but whenever that event happened and I didn't want that to happen, then how we control it? So, and I had no answers to it. So just wanted to find it out, like what would be, from your point of view, a better response in place of not answering at all, or how to handle these type of situation. Thank you.
So Milinji, this is a very, very difficult situation to talk to family, friends, and loved ones. So starting early and being persistent and trying to explain to them why it is important for you to talk about these things. Once they get that feeling.
I was on call and they went for a walk. Dinner done?
Anita ji, you are on.
Sorry.
The important thing is give people a really good understanding of why it is important to you as a person that you want to discuss this. Why you want to have this discussion now rather than later. And sometimes it takes 2 or 3 or 4 tries, but eventually you get there. I think that's the only advice that I would give. Be gentle, be persistent, and explain why it is. Once they understand the concern you have and the fact that this discussion is important for you to alleviate that concern and get a plan in place, maybe they will come around to it. We have to.
I have a different take on it though, because your values cannot be their values, even though you may come with an understanding that it's important and you want them to understand. They may not be at a place to understand. You have to first acknowledge where they are and accept it where they are at. And once you have accepted it, they say you have to align with them. You cannot work against them. And once you align, you said, yeah, I can see how difficult this is. And if I were in your shoes, I would be struggling with the same issues. But I have heard this information somewhere. Would that be helpful for you? So I can bring in, do you think that'll help? Because inevitable is not avoidable. Inevitable will happen, whether you want it or not. And I want to work with you to make you understand, and maybe I'll understand in the process, that how can we help each other to get there in dignity. So I think when you start doing this, it never lands anywhere. It ends up in a big fiasco, and your values are not important to me. You have to align with me where I am at. You may be up there on a hill, but I'm still here struggling. So either you can come down and get me and say, we'll walk one step at a time and see, we can rest along the way, or you can say, you know what, I'm here. What's your problem? Why can't you come here? So I think those are very sensitive issues and brought in very meaningfully and at the pace that the other person is able to handle. And the second thing is that if they have made a decision today, they have all rights to change their decision tomorrow. And that empowers them, that gives them control back, that I may choose to say, I want to be DNR today, but tomorrow I may change my mind if I felt the situation was different. So that eases up that distress or worry within them and makes them more amenable and open to having those discussions.
So thanks, Niluji. And one of the important points that we make in the presentation is that regardless of whether you make a change or not, it's important for us periodically to go back and look at it and understand whether given our change in life circumstances, things have changed that we want to modify something. So that cycle of repeating things periodically is very important. So 2 more questions. Nishtaji, your hand is next, please.
Anji, thank you. A very, very relevant and excellent session. I have 2 comments. One is regarding the long-term care. My mother, who was a professor at Northwestern University, paid her whole life for long-term care. And when it was time to use it, there was a lot of red tape. So it is really important. And she had John Hancock, which is one of the better ones. And it's very important to look at the red tape because they
Yes.
found different ways of not paying.
Yes.
And they would come up, and you have to have a lot of paperwork and so on, and send it to various places. So you really have to do a lot of follow-up, but do your due diligence, and do look at the whole thing actively. Secondly, regarding my mother, when I had to have a discussion with her regarding at the end of life, it was very difficult. But what I did was I had a friend of mine come in and talk about a recent death that had occurred somewhere. And she brought up the death and said, hey, this could happen anytime. And she brought up the conversation regarding death while my mother and I were present. And I had requested her to do this. And then from there, we were able to segue into death and dying and talking about that.
Thank you so much for sharing that with us, Nishtha ji, and
Yeah.
for what is doing so clearly in difficult circumstance for you. Two pieces of two responses to that. One is the booklet that I described to you, that's in one of the links I sent you, talks about some of the techniques. Precisely, one of them is precisely what Nishtha ji talked about, is to raise examples of what happened in friends or family arena, saying that look at them, this is what happened, these are the difficulties they had. We do not want to be able to face those same things, so shouldn't we be getting ready in some way? So we have to come up with creative ways of getting that initial door open into discussion, and then things go more easily. And the other thing about insurance policies and the complexities, this group with the Hindu traditions and the wisdom of the Gita and so on might appreciate this Western joke. It said, talking about contracts, it said, even if it's written in Sanskrit, they say, read the fine print,
Yeah,
So,
I agree. And there's a waiting period too. I mean, they may have 30, 60, 90-day waiting period.
Typically
So you have
6
to be
months.
mindful of that. Yeah, so you have to make sure that you're actually making that call early on, and not because now you have 30 days or maybe 3 days to live and you can never access that insurance. So be aware of fine prints is where the money is.
So we have one last question from Mahaji, and then we are approaching the hour where we have to close up. This has been a wonderful discussion. We could go on for hours, but unfortunately we have to cut it short. So Mahaji, floor is yours.
Thank you, Mukundji, and thank you, Dr. Neeluji, for being here. I want to quickly get your opinion, Dr. Neeluji, and maybe Dr. Mukundji also, if time permits, is your opinion or your tips for us as the top 3 things to do if someone has the Advanced Care Directive in place. And Dr. Neeluji, you actually referred to that in your lecture, perhaps. So this is a worst case scenario. You have the Advanced Care Directive in place, but it so happens you end up with a medical care team in an emergency, you're in an accident, and you're close to end of life, and you don't have your advocate or your appointed power of attorney with you. How do you make sure, what 3 steps that you can do to make sure that they have access to that Advanced Care Directive?
So Advanced Care Directive is something that most people don't even have time to go through because it's a big document. So in California, there's a form called Physician's Order of Life-Sustaining Treatment. You have to make sure that every person who's dealing with progressive or life-limiting illness has that form signed, and that should be visible either on the refrigerator or the back of your bedroom door, because that's where the EMTs come and they look for that directive. So when they're responding, they look at the form. First thing, they'll look at those places. And if that's not there, by law, they're required to perform CPR. Whether you can tell, no, my loved one didn't want it, nothing doing. They will perform CPR and they'll take them there. The other thing, there have been apps that have come up now. People do their copy of this form and they put it in their wallet, and some people, they just have it in their in a locket or something inside it. So, and in the phone, the apps actually talk to the hospital organizations, and it is available through those. So some things to explore and look at. There's not a foolproof system just yet. And I mean, a lot of bad things happen, even when people have said explicitly we don't want it. But having a POLS form is a good beginning, and every state has that form. It's just called differently, especially in US. I don't know about Australia though, that what the deal is.
Yes,
Mahaji,
thank you.
I
I've heard of that form, especially the EMTs coming to the refrigerator door. My question was addressed more to where you are outside home, you're in a, maybe even an unknown place, but it makes sense what you're saying, and perhaps exploring the app or something else. Yeah. Even to contact your, something even to contact your power of attorney, you know, your appointed, your son or your daughter or your uncle or whoever.
Well, in US, the hospitals are so aware that the first thing we look at who's the power of attorney. Is it scanned, and making sure it's scanned into the health system, because health system are talking to each other. We can get the documents scanned even if you were in someplace else. Our health system will get those documents as long as it's scanned in and it's electronically available in your health record. It would be accessible to us no matter where in the country you are.
Oh, great. That's really good to know. So I'm with Kaiser Permanente and I have my advanced care directive scanned and uploaded there. So that means as long as they know this is my insurance, they will access it. That's really good to know.
We will even get it from outside of the country. If you're Kaiser Permanente, they're really good at it. We will access those documents. We'll send it to them. It would be available no matter where you are.
Thank you. That's really good to know. An excellent presentation, both yours and Mukunji's. Yeah. Lots to learn.
Thank you, everybody. And I'm afraid that on that note, I do have to bring the session to a close. We need to move on. If there are additional questions you have that were not addressed, please do send them to Anita ji and me by email or in any other way in the WhatsApp, and we will try and get your questions answered and resolved the best we can.
Mukunji, can I just say in 1 second on the sentence about the
if it is less than 10 seconds, please. Otherwise, we do have
to. But less than 10 seconds. She was asking question and Niluji answer. I made mine with the lawyer and give my doctor. So that will, like, anytime and every time it's they says, like, you know, they can get it, all my advanced directive.
Yes, and that's possible too. But your lawyer may be dead before you. You never know. The thing may shut down. So it's always a good idea to scan it into your health system.
Yeah, I give my doctor as well as my lawyer has it. Both has.
Yeah, that's perfect. So you will not go wrong there.
Let as many of your family members know as well, so people are informed.
Yes.
So with that, Anita ji,
thank you.
Please close the session.
Sure. Yeah. So just a gentle reminder to everybody, please fill out the graduation forms before, like as soon as possible, because we have, I think, only 3 more sessions, if I'm not wrong. And also please reach out to Usha ji for your own dollar projects, whatever you have decided or come up with, so that she has those in place and you can get them going. So. Those are my closing comments, and please reach. I think some of the I was not included in the Australia group chat, so I was just posted my email, personal email over there. So if anybody wants to reach out with any questions, please feel free to do that. So we can close the session now. I'll just open the closing prayers here. Everybody can please close your eyes. Let's close the session. Om Sarve Bhavantu Sukhinah, Sarve Santu Niramaya, Sarve Bhadrani Pashyantu, Ma Kaschit Dukkha Bhagavet. Om Shanti Shanti Shanti. Thank you. Hope everybody has a great day and great weekend. So enjoyed every conversation of this session. So even though it was 2 hours, I was initially thinking 2 hours is a long time for post discussion, but this was really good.
Thank you.
And
Thank
with
you
that,
for
my
joining.
thanks to
everyone.
Neeluji
Thank you,
also for attending the
Mukunji.
session
Thank you,
today.
Gauravji. It's a wonderful session.
Thank you.
And thank you so much, and enjoy the weekend, all of you.
Thank you for
Thank
having
you.
me. Bye-bye.
Bye-bye, Neeluji.